Welcome, everyone, to the Pawsitive Veterinary Dentistry Podcast, the podcast dedicated to helping veterinary professionals elevate patient care through better dentistry, better diagnostics, and better decision-making. I'm your host, Benita Altier, licensed veterinary technician specialist in dentistry, and the founder of Pawsitive Dental Education. Whether you're listening in general or specialty practice, academia, or still in training, this podcast is designed to give you practical, real-world insight you can take back to the dental table. Today is reading between the roots, common interpretation errors in veterinary dental radiography. This is such an important topic because dental radiographs only help our patients if we truly understand what we're seeing. And just as importantly, what we think we're seeing radiographically, interpretation is one of those areas where I see the most frustration, hesitation, and second guessing among veterinary teams. Questions like, is this pathology real? Is the imaging diagnostic? Am I missing something important, or am I overinterpreting what I see? That's why I'm so excited about today's conversation. Joining me today is Brenda Mulherin. She is a boarded veterinary dentist, diplomate of the DAVDC, and clinical professor with Lloyd Veterinary Medical Center College at Iowa State University. She is an expert in veterinary dental radiology, and I'm so excited that you're here today.
Hey, Benita, it's great to be with you.
Thank you so much. This is such an important topic, and I knew this would be such a game changer for a lot of veterinary professionals out there in regards to feeling more confident. And I think that's one of the things that we really like to do with people is help them feel more confident. I feel like veterinary medicine is so difficult as it is sometimes, and I think we wind up second guessing ourselves a lot when it comes to dental radiography. So before we get started, Dr. Naomi Hoyer has left you a question.
All right.
And this is kind of fun. It's going to be the cliffhanger at the end of every episode, and you will get to ask a question as well. So her question to you is, if you see a patient signalment on your schedule, is there one patient signalment in particular that makes you go, oh no?
Ooh, that's a great question. I think from a dental aspect, I think that whenever we look at small patients, so patients that are going to be, less than 10 pounds and things in that respect, I think we already start to, formulate in our minds what kind of a train wreck or a disaster that patient could be, especially when you're related to veterinary dentistry. So I would say in general, probably a brachiocephalic where I'm kind of like, ugh, that could be a hard press for me. I think that those are probably the ones that we get a little bit more twitchy about just because those teeth are usually under-erupted or completely unerupted. They're crowded. You have a lot of those cases just in general that have like the hair that is stuffed in between all the different teeth and the roots, and you're not only digging out the hair and the teeth, but you're digging out random toy stuffing, and you're digging out all sorts of other things that could be trapped, and then you add on all that debris that you can collect in the palatal folds, the rugae of the hard palate. So I would probably say just in general the brachiocephalics. I think the other signalment is just old. Like if I have something that's coming that's 14, 15, 16 plus years old, I'm like, ooh, what other comorbidities am I going to have to manage at the same time as trying to do a dental cleaning and assessment and treatment of any of the disease that could be in there?
Yeah, definitely gives you a little bit of pause, so to speak, when you see a patient is on the schedule that you're really already anticipating some specific tricky situations, especially when it comes to the anesthesia for that patient. And we could have a whole nother podcast in regards to, how we deal with that. But I'm sure as a veterinary dentist, you also realize you are the last stop on the train, and that, these veterinarians are really depending on you to be able to tackle whatever it is that they didn't feel comfortable with. And in my last episode with Dr. Hoyer, we talked specifically about when it is appropriate or when should we refer patients. So, getting to you is kind of the last step, as I mentioned.
Absolutely.
So, you've reviewed thousands of dental radiographs over your career. When you think back on your early days of interpreting images, What were some of the things that you felt confused or overwhelmed by, and how did that shape the way you teach interpretation today?
I think that's a great question. I think that, when I look at my early career, and I don't want to give the aging of that as far as for when that early career started, but veterinary school in general did not give me the tools to prepare me for treating patients, let alone reading dental x-rays. Like dental x-rays were something that kind of developed as my career progressed. And now we have, even more advanced diagnostic imaging that also helps us to provide more of the 3D image of the structure. Dental radiographs, I believe, are very affordable for general practices, and they are also very, very helpful to be able to give you more information as to how you can treat and practice a higher standard of care more than just wiggly tooth dentistry. And I think that is where it helps. But like all of my training was when I was in my first practice in Illinois, was from someone like you. It was a veterinary technician, but not specialized in dentistry. It was a veterinary technician who taught me how to extract teeth. And then I took the initiative to go to wet labs and to try to learn more to figure out. I mean, they use the phrase, it's like pulling teeth. That phrase is there for a reason. Like pulling teeth is something that is not necessarily going to be easy unless you practice and develop those skills and kind of that muscle memory to be able to figure out how to do it. So, looking back when I started to read x-rays, it's very easy to overinterpret. And that's what I tell the students as well. I have a game with them that I play that's a take on Jeopardy that I call Mulhern's Wisdom Tooth of Knowledge. And, I'll put up images and I said, is it a pathology or is it anatomy? And 90% of the time, they'll always tell me that it is a dentigerous cyst, or they will tell me it's an abscess. And what it is it's the mental foramen. It's normal anatomy. And so then we get to have that discussion then. How do you discern a pathology from anatomy? And what resources do you have in your clinics that you can use to try to discern those things? So by looking at the other side, fortunately, if the animal has the other side there and it hasn't been removed for some other disease process, the animals have their own controls. So you can look at the other side. You could look at a skull. You could look at other images of animals that, of that particular region that you may have x-rays of. You look at your textbooks. You can look at, a whole myriad of other things to be able to help you decide. And then again, taking a different view. Maybe you elongate the image. Maybe you foreshorten the image. Maybe you, as opposed to going straight on as a parallel, maybe you shoot it from kind of front to back or back to front and see if whatever that area that you're suspicious of, does it go along with the tooth root or does it move away from it? And if it moves away from it, it is, potentially something that may be anatomy and not something you need to be concerned with.
Yeah, I think that's such good advice. In fact, that was one of the questions that I had for you is we don't want the veterinarians to not necessarily trust what they see, but they also need to be curious and also understanding that this is just a two-dimensional image of a three-dimensional object. And how can we do more images to potentially gain the trust of what we see in regards to looking at that potential pathology being repeated over multiple images? And if it's not, what should our next moves be? I would say before we even talk too much about interpretation, we really should talk about image quality. I don't want veterinarians, I'm sure you don't either, to start interpreting images that are not even of diagnostic quality. So could you further define what you think they should be looking for before they even start interpreting in regards to, is this image diagnostic quality, or should I have my technician take a new image that would better suit the realistic appearance of the teeth and the bone that I'm looking for?
Absolutely. I think it might even start a little bit before that, Benita, with
Okay.
having a grasp of what you should be looking at, knowing the number of roots that should be present, knowing what direction those roots should potentially be pointing, and having that grasp. Then when I am teaching dental radiographic procurement or taking those images, we look at a few different things. We look at contrast. Is the image too light or is the image too dark? I tell the students when I give my lectures in their third year radiology course, I talk to the students, and if the image is too light, it's like you have underbaked the cookies. You don't have enough heat, you don't have enough radiation generation to be able to penetrate that bony structure. So you need to up it. You need to up the temperature or up the time. So, to get a cookie that is going to be very nicely baked. Alternatively, if you turn the oven on to 500 degrees and put it on for 40 minutes, your cookie's going to be black. So you've overbaked the cookie. So turn down the heat, turn down the temperature, turn down the time generation to allow those images to be able to have a diagnostic quality to them. So I think the contrast of the image is very important, because sometimes if you have too much contrast and the image is too dark, it can make it appear that there are portions of the tooth, especially right around the neck of the tooth, are missing and could resemble tooth resorption, especially if you're taking those images in a cat, which it may not be. So contrast, I think, is very important. The other thing is, the positioning itself. So some of the common artifacts that we can create are going to be either elongation or foreshortening. And foreshortening meaning I look at the teeth themselves and they kind of look like that they're slumped or squatty. And they kind of look like little mushroom heads on the top of it. So, you want to have an image in which it will give you as appropriate diagnostic interpretation ability to what it would look like if you had extracted the tooth in its entirety and were looking at it on your countertop. So, looking at foreshortening as being too squatty. Alternatively, if the image is elongated, that can also create radiographic artifacts. Elongation, I think of that like stretching the teeth out like saltwater taffy, like where they're all stretched out and they have those long, long roots to them. The other thing that I see, especially when I get images that are submitted to me, is not including the entire apex. I can tell you what's going on with the crown of the tooth, because the crown of the tooth I can see visibly and clinically and incorporate that with my clinical exam, but I can't tell you what's going on with the roots. So I want at least 2 millimeters plus of the apex of the root, below the apex of the root, so that I can make sure that there's no periapical lucency, potentially that there's not a root tip that was pushed somewhere where it shouldn't have been, that there may not be a cyst or a mineralization of, kind of that. Sometimes we'll see those mineralized areas of osteosclerosis within the mandibular canal. Our radiologist always calls it a root bomb because it looks like a mineralized structure in the mandible. So, you want to have the area to be encompass the entire area that you're looking for, plus some.
Right.
So I think positioning and contrast, and then having a grasp or a knowledge of what it should look like to begin with.
I think that's really valuable. I often think of the most common disease that we see in our dentistry patients being periodontal disease as being the most important thing that we're often really looking at when we look at the dental radiograph. So the bone surrounding the tooth roots is actually what I call the house the tooth lives in, which is often the reason that teeth get evicted from their home, is because the home cannot be inhabited any longer. It's too far gone, right? So making sure that you can see enough of the house or the bone around the teeth to make sure that we can interpret that properly is always that message that I preach.
Absolutely.
I also, when you're thinking about what's the first things, like you as a veterinarian, if you stepped in front of a computer screen and there was a dental radiograph there, I know you do these processes automatically in your mind, but do you have advice for the listener in regards to what they should think first when they see the dental radiograph in front of them? They haven't seen it, now they see it. What should their first steps be? I know you mentioned making sure it's not burnt cookies or it's too light, right? So contrast is super important. But what else would you say would be like your mental checklist or your mental steps when it comes to looking at a dental x-ray?
So another great question. So I do a lot of our radiographic interpretation for one of the other primary care doctors that does dental procedures. So when I come into the room, they're like, "Hey, we're ready to read the radiographs." The first thing that I do is I look to be like, okay, is it contrasted? Is it well positioned? If all those check, the first thing that in my mental process is I think, is it maxillary or mandible?
Okay.
Is it right or left? And then that allows me to at least know where we're at in the oral cavity, what teeth I should be expecting. From there, I look usually at the bone height to say, does it look like that there is any evidence of any horizontal bone loss? Horizontal bone loss, I look at that as it going across the horizontal plane of the tooth. So, kind of parallel to, that upper alveolar bone margin surface. So I look, is there any loss of bone that would be anticipated to be either less than 25% bone loss, 25 to 50% bone loss, or is there greater than 50% bone loss? From there, then I look at either side of the roots of the tooth to identify whether there is any vertical bone loss. So vertical bone loss is going to be more so bone loss in a triangle or an angular shaped defect, and it is usually associated with a singular surface of a root of a tooth. So even in a multi-rooted tooth, it could be the front or the back, but it's a more triangle shape. I think it's easiest to probably see vertical bone loss associated with a canine tooth or the mandibular first molar tooth. Those are the times that I usually see the most vertical bone loss, but it can be associated with any tooth. So if it's a very sharp, angular, and only associated with one side of a tooth root, that's going to be that vertical bone loss. From there, I then look at the pulp canal size. So the pulp canal is the blood supply or the guts of the root of the tooth. The chamber is kind of within the crown. So I look at each of the root canals to say, are they bigger than the surrounding roots or the bigger than the other surrounding tooth root pulp canals, which that can be an indication on whether the tooth is vital or non-vital. Alternatively, if it's not too wide, it could also maybe be significantly more narrow, in which there may have been some sort of an inflammatory process in which the pulp canal itself was obliterated and filled with some sort of a overproduction of dentin that just basically got rid of that pulp. So after I look at the bone, I look at the pulp chamber size, and then I start looking to follow around the periodontal ligament. Or the periodontal ligament space, I should say. So the periodontal ligament space is that radiolucent space that surrounds each of the tooth roots themselves. And I look, is it present or is it absent? And then after I find out if it's present or absent, is it wider than what it should be? And is it wider because of my positioning? So that's where that positioning comes to play. If the image is very well positioned, you may want to have your technician or you take another image of that tooth, which either elongates or foreshortens it. And if it does appear that it is wider, then maybe that is true evidence of pathology. I feel like that the biggest error that people make, especially when they're over-interpreting, is that they are not correlating what their clinical exam findings are with what their radiographic findings are. If you just strictly take your image and, make all of your decisions based on your radiographic image, you're probably going to miss things. For example, it is very difficult to tell whether there is pulp exposure on a complicated crown fracture based on an x-ray. You need that clinical exam finding. I mean, unless 90% of the crown is missing and it's obvious, but that is where some of those things cause an issue and cause either overinterpretation or underinterpretation of other things, especially in cats too, concentrating and focusing on that periodontal ligament space, on whether it's present or absent, is going to give you a indication as far as for what potential treatment options you have, especially when there is evidence of tooth resorption too.
Exactly. Yeah, tooth resorption is definitely something we can touch on here in a bit, because I know that's definitely something that confuses people a lot. But I really appreciate the steps that you gave, because I feel like this is really going to be some key takeaways for the listeners today, where they need to learn a specific way of going about looking at their dental radiographs. And I also really appreciated that you mentioned don't even start down the path of looking for pathology or interpreting until you're sure that you've identified what's in the picture, that the image is oriented correctly. Because I feel, and I'm sure you do as well, that we shouldn't start interpreting images that are oriented upside down on the screen, or we never want to flip images either way, but we want to be very sure that we can identify maxillary versus mandibular and not necessarily depend on any labeling on the image, because potentially the labeling could be incorrect.
Absolutely.
And we have to not use labeling as a crutch. We really need to have a deep enough understanding of how images are acquired and what we're looking at on the screen to orient them properly before we even head down that path. I think that overinterpreting is a big theme of today. So is there a time when you looked at a dental radiograph and were pretty sure that you saw some specific pathology, but then you looked at the patient clinically and didn't actually correlate what you were seeing radiographically? When that happened, what was your next steps, and what would you recommend the listeners do if they run into that type of situation?
Oh, yeah. You got some good questions for me today. That one's a really good one. I think with, yes, there absolutely has been times. So if I see an image and I'm like, gosh, that looks like it's a wider periodontal ligament space than what I would like for that tooth to have. The first thing I do is I check my positioning, I check my contrast, I check all of those things, and then I will usually have my technician take a different image somewhere or another in which they're elongating it, foreshortening it, to see if I can change it or alter it, or if it is still there. If I still am like, this kind of still looks sketchy, but yet not sketchy enough for me to say, let's just remove it or treat it, I use the other side as a control. So I'll put up the two images adjacent to one another to compare the two sides. Because if both sides have that same appearance, I'm more apt, and clinically the tooth looks okay, I am more apt to think that it is probably an anatomical variation versus an actual pathology variation. If that patient doesn't necessarily have that, then I kind of look at the overall patient itself. And so if I have a, 14-year-old diabetic train wreck that, is not a great anesthetic candidate, I may give the owner the call and be like, hey, I'm a little bit concerned with this tooth. I can't necessarily truly tell you whether there's something wrong with it. We can either watch it and have you come back in 6 to 9 months or 9 to 12 months for another radiograph and deal with it at that time. Or if you tell me that you never want to anesthetize this dog or cat ever again, we can be more aggressive and we can extract it. And, based on my interpretation or my assumption of what I have a concern of is going on.
Yeah,
So
that's such
I
good
do
advice.
I do try to involve the owners into those things. If they say, "What would you do if it is yours?" then, I kind of use my intuition or my gut, and again, if they are willing to keep it and willing to come back, I probably play a little bit more conservative. Many of my colleagues that have more, unfortunately at Iowa State we don't have cone beam, at least at this point, so using a different imaging modality would also be very helpful. So cone beam definitely gives you that ability to get that 3D image of your 2D structure. So, that would also be a great way to be able to try to ascertain whether that truly is pathology or not. But most general practices don't have that. So then we concentrate on the variation of the radiographic positioning, our clinical exam and how that looks, and then that honest conversation with the owner.
Yeah, I think that's important. The client, the pet parent has to be on our team, and they really need to have some things explained as well, especially when it comes to going down the path of euthanasia, right? Because we can't reverse that. So if you feel that if this is one of those kind of top 8 or 10 strategic teeth that we all like to save, and potentially what you're seeing there isn't something that is deemed to be, potentially really like an obvious pathology, right? We probably want to err on the side of being conservative and not extracting the tooth versus, if you have that patient that's never going under anesthesia again, maybe we don't want to take the chance that this could be something that's either a ticking time bomb or it's currently painful. And, certainly dentistry, we know, doesn't tend to get better on its own if we don't treat it. So,
Absolutely.
yeah, that's a really great thing. So, speaking of normal variations, I love that you mentioned that you look at the other side of the patient's face. And I think that's just so critical because, as you mentioned, they are their own control set, where if we don't see something similar on the other side, then we'd be more concerned. Because I have found through taking dental x-rays full mouth on thousands of patients over the last 24 years that they often are very symmetrical in what's normal for them. So I think that's always just a really good piece of advice. How does studying normal images really build confidence over time? Because I think some veterinarians think that, why take x-rays if the patient's teeth look normal on the outside, which we know, and you and I both preach the same message, that we don't know what the roots look like. We don't know what the bone looks like. The crowns could look perfectly normal and we still need to take dental x-rays. But it's not a waste of time to spend the time you need to interpret normal images. How do you think that really builds the confidence of the practitioner over time as they continue to do that?
Yeah, especially, the more normal images that you can look at, it's just like anything. The more hearts you listen to, then, the more that you can pick up the sounds when there's a murmur or if there's an arrhythmia or if there's something else that's going on. I mean, the same is in effect for dental radiographs. The more that you can look at what a normal tooth looks like as far as for where the bone height should be, as far as for what the periodontal ligament should be. A lot of the students kind of get tripped up a little bit, especially when they're looking at the mandibular incisors and they see that wide fibrocartilaginous symphysis. They're like, oh, there's disease. And we're like, no, that's pretty normal for this. Or, yeah, maybe there's a symphysis laxity to it, but as long as the animal's not clinical, it's not that big of a deal. So I think that, when you are looking at these patients and you can see, you miss more by not looking than by not knowing. And I think that that's the most important factor of this. And yes, just because clinically the teeth look appropriate, that doesn't mean that radiographically there might not be some hidden iceberg that is underneath there. I had written up a case report in the Journal of Veterinary Dentistry, and it was about a young dog that had come in with a swelling to the side of the mouth, and it had a beautiful full set of teeth, and there was an extra supernumerary tooth that was impacted within the bone that was causing an issue. So the group out of Davis, Dr. Verstrati, and all of those doctors out at UC Davis have two fantastic articles about the diagnostic value and diagnostic yield of full mouth radiographs in dogs and cats. And they found as well that there's a very high percentage of dogs that had completely normal clinical exams had pathology. And ones that had pathology, dental radiographs found more pathology that they wouldn't have found by just looking at that clinical exam on both canine and feline patients. And the percentages are pretty striking. I mean, it's usually like right around, at least 25% up to 40%. So, I mean, it's a really, really great, well done study by that group that is the basis of what I always recommend to owners and to students and to general practitioners, to be like, it's really imperative to be able to take those radiographic images of the full mouth so that you can provide the care that your pets need, or to give you a heads up if there's a super curly dilacerated root in there. That may not be one that you want to tackle, and it may be one that you want to unfortunately send my way, I guess, to try to tackle.
Exactly. Yes. So I think we can link that particular article and some of that information in the show notes, and that would be a great place for people to go to learn more. I
Sure.
know that Dr. Verstrati had an amazing article published on dog tooth resorption that I always refer back to because I felt like in the beginning of taking dental x-rays, people thought tooth resorption was just a cat thing. That particular study of, I believe, 242 dogs in the study. Yeah, it really showed the incidence of tooth resorption in dogs is also extremely high. And how do we look at that to document our findings and decide what the appropriate treatment is? I felt like that article was extremely revealing.
Mm-hmm.
And it just goes to show that if we weren't taking full mouth dental radiographs on dogs, we weren't finding tooth resorption. It wasn't something new that was suddenly occurring. It's just we were not looking for it, right?
Absolutely, yeah.
And so you look and you're going to find, and this is hence where the kind of confusion comes in when it comes to, oh no, now we found these things, like what do we do about it? Again, a whole other podcast episode waiting to happen, but specifically with tooth resorption, which seems to be one of the most confusing and I would say emotionally charged findings when it comes to interpreting dental radiographs. Why do you think this condition is so challenging to interpret specifically?
Well, I think for cats, it has been accepted that tooth resorption has occurred in, cats throughout the decades. And that's definitely something that we recognize. So there's the staging system as opposed to how much of the tooth itself is being affected by tooth resorption, as well as the type and whether there is that intact periodontal ligament. I feel like that there's more research out there as far as for being able to offer different treatment options for tooth resorption in cats as well, and looking to see that, if you do have one of those type 2 lesions and you don't have any radiographic evidence of a intact periodontal ligament space, it could be appropriate to do a crown amputation, provided that you have all the rest of the criteria that would make that cat be a candidate for it. So no evidence of gingiva stomatitis, your feline leukemia or FIV, feline immunodeficiency virus negative patients, cats that don't have evidence of periodontal disease or endodontic disease, or the cats that have radiographic evidence of an intact periodontal ligament. You can't have those. You can't do the crown amputations, or you shouldn't do the crown amputations. With that, crown amputations are obviously way easier than to have to dig out those tiny little fragile glass-like tooth roots out of there. So it would be much easier to be able to just crown amputate everything. But the problem is if you don't have those criteria, you're not necessarily doing right by that animal to leave those structures that are in there. I would say in general, what I find is even when I go to try to extract the cat teeth that have evidence of tooth resorption, the tooth itself is hardier than what you see that it looks like radiographically. So I kind of intend to go in with all of mine intending to still remove them all in their entirety. But if I don't, or the anesthesia portion of it starts to go sideways, or time-wise, it's like, gosh, I'm really keeping this animal under a long period of time, I kind of do a lot of modified crown amputations with that to try to, remove the portion of the tooth that is thought to be uncomfortable, that is still above the gingival margin, and then allow that cat to then try to heal up and fuse the rest of those tooth roots to the surrounding bone. Dogs, alternatively, are a little bit trickier because, in theory, crown amputations are not accepted practice in dogs. And I think it's just because we don't have the long-term follow-up for those particular patients. We don't necessarily know if that is an accepted treatment or if that's going to cause problems in the future. The problem is that those teeth are just as fragile as the cat teeth, only they're bigger. So I think that can be very, very frustrating. And I think everyone accepts that cats get tooth resorption. Everybody accepts that. But then they're like, oh no, what happens when it happens to a dog? And we kind of like lose sight of what we're supposed to do. So I do concentrate a lot of times on that Verstrati article as well on the tooth resorption. I probably play things a little bit conservatively. If there's clinical evidence of tooth resorption on any tooth, whether it's a dog or cat, I'm going to go in and try to get out the majority of the tooth structure that is left. And in dogs, I make a greater effort to try to get out the entire root if at all possible. Whereas cats, I might lean a little bit more onto the crown amputation portion of it. If that resorption, or it's more that external replacement resorption where it looks like that the root itself is fused to the surrounding bone and it's not yet encroached onto that clinical surface or above the gingival margin, I have a tendency to play them a little bit more conservative and just tell the owner, yes, this patient has tooth resorption, but until it encroaches onto that cemento-enamel junction or on the crown of the tooth, I am more apt to conservatively monitor them because at this point we don't necessarily know if those patients are uncomfortable or if it is something that actually is going to progress and into the loss of the tooth. And I think that's the hard part, with dogs or cats. Just because they have evidence of tooth resorption doesn't mean that it is necessarily going to progress in 3 weeks, 3 months. It may be 3 years. So each animal is individual as far as for that progression of how quickly tooth resorption can encompass the entire tooth or the root.
Yeah, definitely. Can you give us some tips and tricks when it comes to looking at a dental radiograph? Let's say it's a cat, because obviously, people are very focused on cats and tooth resorption. What would you look for in regards to deciding whether or not this tooth is okay to have intentional root retention and crown amputation versus someone feeling confident that they need to go in and extract that whole entire tooth root or tooth roots if it's a multi-rooted tooth?
Yeah, I mean, I think if you got 100 veterinary dentists in a room and you asked them that question, I think you'd get 150 different answers. So I think that for me, it is whether there is evidence of that intact periodontal ligament space. So if there's an obvious periodontal ligament space and it is a type 1 lesion, that root needs to be removed in its entirety. There's kind of no ifs, ands, or buts about it. If there's looking at that radiograph, if there is no recognizable periodontal ligament space and there is no evidence of an abscess or anything, it would give me an indication that there was some sort of an infection along with that root. Those are kind of the two things that I would look at. Plus, then I go back to my history and my clinical exam and no evidence of gingivostomatitis and no evidence of feline leukemia or FIV that could be associated with it. And for those, I'm relatively comfortable in choosing the option of doing the crown amputation. There's always a risk. I think I've had one in which I've performed a crown amputation and a little portion of the root did fester out a few months later. But, even looking back at the radiographs, to see like, ooh, did I miss something? Or, why did this kind of fester itself out? I still would have made the same choice. We don't really know what the body is always going to do. Fortunately, in this particular case, the owner had something very similar that happened to themselves, and they're like, "Oh, the cat's like me," and so they were very much understanding in that situation. But uh, you know, the biggest take home with tooth resorption is that you should not be performing crown amputations without having taken dental x-rays. So I don't care what the tooth looks like on the crown. You need to prove to me and demonstrate that there is no obvious intact periodontal ligament space present in those x-rays before you're going to choose to do a crown amputation.
Perfect. You described type 1, type 2, and I know there's a type 3. Could you further
Yep.
define that for the listeners so they can understand what we're looking at?
Absolutely. So when you look at a dental x-ray, there are three types of tooth resorption. Type 1 is where you can see an intact periodontal ligament space present. Type 2 is where there's no recognizable periodontal ligament space present on the radiograph of either root. And then type 3 is in a multi-rooted tooth. You have one of each flavor. One root has a periodontal ligament obviously identified, the other one no longer has one. So for those, treatment of those would be in which you could technically do a crown amputation on the type 2 root, but then you need to extract the type 1 root in its entirety. So
Gotcha.
along with the three types for tooth resorption, and these are specifically in cats, because in dogs there is no staging system to my knowledge anymore. I know that Verstrades described them, but there's not the true staging system as there is in cats. The stages of tooth resorption there are 5 stages. Stage 1 is where the resorption has eroded into the enamel or the cementum. Because those two structures are so extremely thin, there's no real radiographic evidence of those. That would be something that you would find on your clinical exam when you're putting your kind of periodontal probe the explorer end around where the cemento enamel junction is around that tooth surface. Those are the only ones you're going to catch clinically. Stage 2 is where it goes into the dentin. So this is a stage where you will start to see some loss of the tooth structure. So it's gone through the enamel and dentin, or through the cementum and dentin, but it hasn't invaded into the pulp. So in stage 3 is where it invades into the pulp. So this is where clinically you're going to start to see that little fleshy response, like where you get a little bit of a soft tissue because the pulp is exposed and you get a little bit more of an inflammatory reaction. But in stage 3, the majority of the tooth structure, both the crown and the root, are still present. And then stage 4, because they try to make things complicated, stage 4 is divided into 3 different subsets, A, B, and C, where it invades into the pulp of the tooth, but you're starting to get a significant amount of structural damage to the tooth. And it's divided into, are the crown and the root affected equally? Is the crown more affected than the root, or is the root more affected than the crown? And then stage 5 is the ones in which Mother Nature pretty much did the job for us. You just have a hump of tissue with maybe a little bit more bone there than what you would normally want to see, but it's healed up, and radiographically you just kind of see some hints of what I like to call ghost roots, like where there's no real inflammatory component that you see obviously, but you see where there should have been a tooth and there no longer is a tooth, but all the bone in the gingiva looks healed up over the top of it.
Right. And sometimes the tooth resorption isn't recognized, and especially cats, until someone notices there's a hump where there used to be a tooth, right? And
Yep,
unfortunately, the cat has been suffering in silence for months to years before
for
that
sure.
crown ever broke free, and everything wound up healing over the top of that and quieting down. So, thank you so
Absolutely.
much for defining that. I know it can be really overwhelming, and I'll put a link in the show notes to the American Veterinary Dental College website which will help people understand a little bit more about defining tooth resorption stages and types, because I know there's some good images, diagrams, definitions, and things there that would help the listener understand that a little bit better. Just so that we can narrow this down, just kind of thinking over some of the important things that we can take away from this episode today. Are there any specific, I guess, tips, tricks, anything that you would want to impart to a general practitioner in regards to having a good strategy when it comes to interpreting dental radiographs on a daily basis, or anything else advice-wise that you'd like the veterinarians or technicians to know?
I mean, I know earlier in the podcast, I had used a phrase of you miss more by not looking than by not knowing. And I think that that is the most important thing. If you are not using dental radiographs to be able to look at your patient's oral cavity, to be able to identify teeth that may need to be addressed, or to find problems that you may have. So, for example, if there's an extra root, or maybe the roots are fused together, dental radiographs can really help you with your treatment plan to be able to try to make things more efficient, or it may be, give you an ideas of like, this might be over what I'm comfortable doing, or even talking to the owner of this might be something that we need to stage and do one side versus the other side. I also think that it's very impactful to owners, especially, those little dogs that don't have a lot of bone there that are associated with the mandible, and having that information related to dental x-rays to show the owner and demonstrate, this is why you need to follow my instructions. This is why no tugs, no toys, no chews, soft food only for the next 14 days or 4 to 6 months, depending upon, whatever you're looking at to try to heal. Because of these things, I think it's very impactful for them to show your value and your worth as a general practitioner, to say, this is why we don't just charge per tooth. This is why we kind of charge for our time. And because of the fact that, look at how big these teeth are and look at how little bone this is where my expertise is in relating to trying to treat these teeth, and why you need to bring them back every 6 months so that they all don't end up in your sock drawer somewhere.
Yeah, dentistry is a lifelong pursuit. And I think that that's something that we want to keep in mind too. We may have an elderly patient that potentially is at the place in their life where we cannot anesthetize them every 6 months very easily, or the owner can't necessarily do home care or do some of the things that we want. But our purpose is to really help to educate the public and the pet owning parents out there that really need to understand a little better what our goal is here, so that we can take these patients from, hopefully, they're not in pain, but if they are, make them less painful, infected, and inflamed, right? To give them a better quality of life. So if the listeners would like to learn more, I know you have a book. Would you mind telling us a little bit about your book and the evolution of you writing a book? Because I know that's a big thing to take on, something that I've only written chapters. I can't imagine writing a whole entire book. But what were you hoping that people that pick up your book could get out of that?
Absolutely. So it's definitely a labor of love. That's what I would say. And I think that the publisher had caught me at a weak COVID moment. So that's when I had agreed to do it, was in COVID. So biggest thing that me as a specialist in an academic institution, I am here to be used as a reference for general practitioners and try to help. I feel like I can affect more change by giving your listeners, whether they're the technicians or whether they're the veterinarians, to give them the tools to be able to have an easier ability to diagnose and treat the patients. So I created a veterinary oral and diagnostic imaging book. It is very much geared towards general practitioners and, mixed animal practitioners, small animal practitioners, people that are interested in exotics. And then I begged and pleaded for a lot of my colleagues and friends here at Iowa State, along with my resident mates and other friends that I have met along the way in this profession to help contribute to it. So it is kind of an all-encompassing, inclusive book that talks about the history of dental radiography in general, how to take dental X-rays, normal anatomy, and it's built in a way where you would have a normal image that's unmarked next to an image that is marked up to show you all those anatomical structures. Both, common conditions that we see in dogs, common conditions we can see in cats, some of more uncommon conditions that we can see, and there's an oral surgery chapter that talks a little bit about some of the different types of neoplastic conditions that you can see. We switch from the small animal companion side, and then I have enlisted my colleagues who have, there's a zoo and an exotic animal chapter that is in there as well, to say those particular species have a lot of issues, especially in radiographic procurement, because they're so small, or alternatively because they're so big, for those that do have some ties to zoo medicine and some of the complications that we can see there. So, and that chapter kind of talks about some of the conditions of the different species, as well as how to image and radiograph those. And then there is also a chapter on equine, because we can't forget our horses as well. So I am by no means an expert on horses. That's why I elicited my colleagues here at Iowa State, and Dr. Molly Rice, also, who's a boarded equine dentist, to try to help create those chapters, to do very similar things with the skull x-rays, and talk about some of the most common conditions that you will see in horses. So it's kind of an all-encompassing veterinary diagnostic imaging of the oral cavity.
When I got the book, I was so excited to read through it and learn from you and get some really good information that would help me be a better instructor when it comes to dental radiography, and have a really solid resource that I can recommend to people so that they can learn more about normal versus abnormal and a lot of the things we've been talking about today. So yes, thank you so much. And I will link the book to the show notes as well, so that the listeners can find that wherever they buy books. I know you can get digital copies as well as actual printed copies of this book, and having these resources in your hospital can really make a big difference, especially right in the middle of taking dental x-rays. You may have questions. Also, just to wrap it up with this, if someone does have dental radiographs that they're concerned about and they're not quite sure what they're looking at, do you have any specific recommendations on having a experienced veterinary dentist like yourself interpret these radiographs for them? Maybe not while the patient's under anesthesia, but between this particular dental visit and the next, so that they can better address the disease or what they're concerned about.
Absolutely. Like I think that it is always good to get a second opinion. So whether you're using some of the colleagues that are in your practices, or I know that there are some dental radiographic imaging services where you can send the radiographs to. Some of them are actually almost like a stat read of them too. So you may be able to utilize some of those. But I think it is always worthwhile. Whenever I get images, I read the images, and then I kind of critique them. I'm like, ooh, this is a little bit too dark, or this is not really a very diagnostic image, or yeah, this is a great image and this is what I see. So I think it's important I use those as very much learning sessions for both the person that is submitting them to me, as well as giving them the information that they need to be able to treat that case. But yeah, I think it's always a great idea to try to send off images if you have any concerns about them, or just want to have a little bit more information.
Yeah, I think that's wise to think about it as a strategy for getting better at your own interpretation game. If you could bounce these radiographs off an expert, veterinary dentistry expert, I would say, not just radiologist, somebody that really understands the oral anatomy and pathology that we're looking at, because they're going to give you feedback and either confirm or deny what you think you are seeing, so that you can get better at doing your own interpretation as you need to in your practice while the patients are under anesthesia. Because sometimes, again, it's not as easy to have that stat resource potentially. I think it's helpful to create a relationship with a veterinary dentist that you would potentially refer cases to, because that person could potentially be your phone-a-friend. I think Dr. Hoyer called it your veterinary dentist in your pocket. Because that way, if you do have that case that's under anesthesia and they are available or they are willing to help you in a more immediate fashion, that maybe you could get at least a little bit of information on what you should do today. And that may be to say you're going to do nothing but refer or get more information via some other imaging that may not be available in their hospitals, like cone beam CT, right?
For sure.
Yeah. So, well, in closing, you get to ask or leave a question for our next guest. I don't know if you had a chance to think through what you might want to ask. Like you said, if you asked, 10 veterinary dentists, you'd get 12 different answers. It's interesting to find out what another veterinary dentist or veterinary technician might have to say about some specific things. So feel free to leave a question that you'd like to ask a colleague.
Yeah, what I would say is mine's a little bit different. So mine is, what would you do if you weren't a veterinary dentist or weren't in veterinary medicine?
I like that. Yeah, so that sounds great. I think we all occasionally sort of question our life decisions. But, sometimes people would be two things at once if they could. So we'll see
That's
what
right.
the next guest has to say about that. So thank you so much. This has been super helpful. I feel that dental radiography is tricky at best. And then when it comes to interpreting, it can be really overwhelming, and gaining some insights and confidence into that world, I think, was super helpful for the listeners today. So thank you so much. I really appreciate you sharing your time and expertise and passion today with us. I really want to thank our listeners for tuning into the Pawsitive Veterinary Dentistry Podcast today. I'd really look forward to having more episodes that can bring really amazing experts and information to the veterinary profession worldwide to help us better understand our patients, the conditions that they are suffering with, and things that we can do to really help improve their little patient lives. So for now, keep learning, keep asking questions, and keep doing positive dentistry.